Okay, welcome everyone. And apologies for the late start. Trying to get some things sorted out. But as people come in, we have 4 presentations for this self-care session. I'll introduce the speakers as for each presentation before they present, and then at the end we'll have some time for Q&A. And our first presentation is by Eden Demise, who is a research associate with Population Services International, and will be presenting on the market landscaping for sexual reproductive health self-care interventions, insights into the enabling environment in Mozambique. So welcome, Eden.
Thank you. Hello, everyone. As mentioned, my name is Eden, and today I'm going to present on our market landscaping for sexual and reproductive health self-care interventions with insights into the enabling environment from Mozambique. I wanted to note that this study was funded by the Maverick Collective and a Maverick Collective donor. The Maverick Collective by PSI is a community of women philanthropists making catalytic investments in health and reproductive rights to elevate women and girls everywhere. Before we begin, I would like to acknowledge my co-authors listed here from PSI and the PSI Mozambique team. Next, I'll dive into background, starting with a definition of self-care. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent diseases, maintain health, and cope with illnesses and disability with or without the support of a healthcare provider. And self-care can take many forms, and the scope of self-care includes self-management, such as self-managing medical abortion, self-testing, such as using home-based pregnancy tests, and self-awareness, such as accessing reliable information on family planning. And this conceptual framework highlights how self-care can be seen from 2 complementary perspectives. One that is people-centered, which is about empowering and building the capacity of individuals to self-care. Another that's looking at health systems, which is about task shifting and optimizing linkages to professional care. And integrating SRHR self-care into the larger health system could have many benefits, including empowering end users, increasing choice, improving health outcomes, and building the foundation for a more consumer-responsive and sustainable health system. It can also help us achieve our universal health coverage goals. Next, I'm going to introduce you to PSI self-care study in Mozambique, which is a market landscape of the enabling environment for self-care for 3 different domains classified by the World Health Organization 2021 guideline for health and well-being. And the 3 different domains include providing high-quality family planning services, recommendations 14 through 21, eliminating unsafe abortion, recommendations 22 through 26, and combating STIs, HIV, and cervical cancer, recommendations 27 through 32. And we did this to inform future research and to incorporate self-care interventions into policy and practice. In addition to Mozambique, we're also implementing this study in Nepal and Malawi, which were all selected to provide a range of self-care implementation experience. My colleague Pratik had presented about our study in Nepal during yesterday's poster session, and the PI, Dr. Kristen Little, had presented on the policy mapping across countries during the panel yesterday. So the overall objective of our study is guided by the World Health Organization guidelines on self-care interventions for health and well-being to describe the self-care enabling environment and market landscape in Mozambique, and to identify evidence gaps to prioritize in subsequent phases. And to our knowledge, this is the first time that landscaping for self-care has been conducted in Mozambique using the World Health Organization 2021 self-care guidelines. I also want to note that this work builds on a similar study conducted by SCARU, the Self-Care Academic Research Unit, and the Self-Care Trailblazers Group in 2020 for Nigeria, Uganda, and Senegal using the World Health Organization 2019 self-care guidelines. And the Self-Care Trailblazers Group sits within PSI, and it's a global coalition dedicated to expanding safe and effective practice of self-care as means to achieve universal health coverage. Next, I'm going to dive into our methodology. So to meet our objectives, we undertook 5 activities between June 2021 and June 2022. First, we conducted a pragmatic review of gray and published literature using databases including PubMed and Google Scholar to summarize evidence base for self-care. Second, we conducted a stakeholder map to identify key stakeholders working in self-care, family planning, safe abortion, STI/HIV, and cervical cancer to administer our e-surveys and our key informant interviews too. Third, we conducted a market landscape where we scanned 1,700 outlets and also conducted epidemiological analysis using sources such as DHS and PMA to analyze the unmet need and the market performance to meet the need for the 3 different health areas I've mentioned. Fourth, we conducted e-surveys to assess the implementation of the World Health Organization self-care guidelines and barriers to scale up, using the stakeholders identified through the stakeholder mapping. And lastly, we conducted key informant interviews to assess the remaining challenges and opportunities to implement the World Health Organization self-care recommendations. Next, I'm going to dive into results. And since the results I'll highlight today are from the e-survey and the key informant interviews, I wanted to give you all a little bit of a background on the respondents to help interpret the results. So for the e-survey, we had 23 respondents. And in terms of occupation, most of them worked for NGOs or for civil societies as providers for academic/research institutions. And in terms of health areas, most responded to the STI health area, followed by family planning. And moving on to the key informant interviews, we had 9 respondents. In terms of occupation, most of the respondents worked for NGOs or for governments. And in terms of health areas, most responded to the FP health area. Next, I'm going to dive into our e-survey results on the implementation of the World Health Organization self-care guidelines, supplemented by the key informant interviews and the desk review findings, starting with family planning. For each health area, we asked the e-survey respondents, are you aware of existing policy or initiative related to each of the self-care recommendations? And this stoplight that you see here summarizes the frequency of those who selected yes, that they were aware of an existing policy or initiative related to each one of the 8 self-care recommendations on family planning. So for family planning, this tells us that there's a higher awareness on existing policy or initiatives for just 3 of the 8 family planning self-care recommendations, which include provision of over-the-counter oral contraceptive pills, promotion of male and female condoms, and promotion of use of condoms with condom-compatible lubricants. However, awareness for other policies, such as on over-the-counter emergency contraceptive pills, were low because emergency contraceptive pills are mainly addressed within the context of and within Mozambique's post-sexual assault guidelines rather than for self-care use. And overall, for family planning, the key informants felt that self-care for family planning is being implemented, but not to the extent that it could be, supported by this key informant quote here. Now moving on to safe abortion. For safe abortion, we see that there's higher awareness for just 1 of the 5 WHO self-care recommendations related to safe abortion, which is on provision of hormonal contraception post-medical abortion. However, we see lower awareness around policies or initiatives for self-assessment for and self-management of medical abortion, recommendations 22 through 24. And the low awareness on aligned policies or initiatives related to safe abortion self-care in Mozambique is explained by this key informant quote, which says, 5 years or so after legalization of safe abortion, access to these services is extremely limited. And for formal self-care, if a woman can go to a pharmacy to buy the necessary drugs and to be able to administer them herself, this is not explicit in the safe abortion guidelines. Now moving on to STIs, HIV, and cervical cancer. Similarly, for this health area, we see that there's a higher awareness for just one of the 5 WHO self-care recommendations for these health areas, which include cervical cancer screening services. Next, and we generally see low awareness around self-collection of samples for other STIs in Mozambique, including gonorrhea, chlamydia, and syphilis, which are recommendations 22 through 29, because even in the health units, testing for STIs is not common, and treatment for STIs are largely based on symptoms, supported by this key informant quote, which says it, as in self-sampling for gonorrhea, chlamydia, or syphilis, doesn't exist in Mozambique. And in the health units, you do the treatment, which is called syndromic. You do the treatment without doing collection. Next, we're going to take a look at barriers. Take a look at the most salient barriers to scaling up self-care from the key informant interviews, both from a policy and from an implementation perspective, organized by these key 3 categories. Some of the health system barriers include lack of enabling policies, availability of products, for example, HPV self-sampling products. And some of the provider level barriers include fear of job loss due to self-care uptake, a need for provider training to support clients, for example, around STI self-sampling. And lastly, some of the consumer level barriers include lack of knowledge or awareness around self-care options and costs to access some of these products and services. Next, we'll briefly describe limitations before diving into my conclusions. The limitations include that this was a pretty rapid assessment across 3 countries, so not only in Mozambique, but also in Nepal and Malawi. And the e-survey self-policy implementation responses were self-report, so there may be additional policies or initiatives that the stakeholders weren't aware of or that we didn't find in our desk review. So in conclusion, we found that among the WHO self-care recommendations, those on family planning were most aligned with current policy. However, aligned policy on safe abortion, STI, HIV, and cervical cancer were largely missing. And some of the key constraints to scaling up self-care that we had just explored include lack of enabling policies, provider fear of job loss, and cost to individuals. So as a next step, we're going to disseminate findings through in-country workshops to inform and develop a healthy, sustainable market for self-care as means to achieve universal health coverage. We're also going to conduct a global webinar with the Self-Care Trailblazers group to share findings with the global community of practice. We also want to make these tools into a public good, which include the e-survey questionnaires and the key informant interview guides, as well as SOPs, for those who want to replicate this study in a different setting. And lastly, we want to build on phase 1, and we plan to conduct consumer and provider insights research in phase 2. And we also plan to conduct self-care metrics research to measure Mozambique's progress in creating a self-care movement under phase 3 of our study. So if you're interested in accessing some of the tools that we've used, please feel free to take a picture of this QR code, and it will take you to where you can download these tools. So I'll take a pause there. However, if you have any additional questions, please feel free to contact us. Dr. Kristen Little, the PI in this project, Marcos, or myself as well. Thank you so much for your time.
Yeah, thank you so much, Eden, for that presentation. As I said, we'll have keep the questions to the end. And I forgot to introduce myself. I think due to the hectic nature of the beginning, I'm James Carrier. I'm the coordinator of contraception and fertility care in WHO. And it's really a pleasure for me to be meeting colleagues who are working in self-care. It's an area that WHO is very supportive of in growing it. So our next presenter is Precious Moturu, and she's the Advocacy and Partnership Coordinator at PSI Uganda. She coordinates PSI Uganda efforts geared towards enhancing and an enabling environment for the implementation of sexual and reproductive health programs, and plays a critical role in advancing the self-care agenda in Uganda as the coordinator for the self-care expert group. So welcome, Precious. Over to you.
Thank you so much. Good evening, everybody. My name is Precious Mutoro Karunga, and I'll be sharing with you about the implementation of the National Self-Care Guideline for self-care in Uganda and how the learnings are informing the best way of integrating self-care for sexual and reproductive health into Uganda's health system. The Ministry of Health in Uganda recognizes self-care as a complementary muscle for the health system, a strategy for achieving universal health coverage, for health system optimization, for involving individuals in managing their own health, but also for prioritizing essential health services. As such, the Ministry of Health in Uganda embarked on a process of developing a national self-care guideline to guide the structured delivery of self-care interventions for sexual and reproductive health, introduction and its scale-up, basically serving as a one-stop point for guidance on self-care in Uganda. As such, the Ministry of Health in Uganda collaborated with partners like PSI and other partners to start the process of developing the self-care guideline in Uganda and adopted a three-pronged approach. The first phase was the inception phase, where we reviewed the World Health Guideline for self-care for health, and also went ahead with the leadership of the Ministry of Health to engage key stakeholders in creating buy-in for self-care at the national level. The second phase is the development phase that entailed 4 different stages. The formulation of the self-care expert group, which is a multi-stakeholder working group focused on advancing self-care at national level and is comprised of implementing and development partners, academia, private sector, and young people. And the self-care expert group working hand in hand with the self-care trailblazer group, which is a global movement for advancing self-care, and works with different partners at the national level to advance majorly the advocacy. And here in Uganda, we're working very closely with CHAD, which is Center for Health, Human Rights and Development. And the second stage here is the selection of the primary focus. Now, unlike other countries, for Uganda, we decided to narrow down on sexual and reproductive health first to serve as a blueprint for the other health areas. And here, the Ministry of Health chose 4 specific recommendations for the World Health Organization for self-care, and that is family planning, antenatal care, HIV and other STIs, as well as post-abortion care. And the interventions and products chosen here and categorized along the pillars of self-management, testing, and self-awareness for self-care are based on the products and interventions that are available in country, in the process of being introduced, scaled up, or already being delivered at scale. And then the third stage was onboarding a national self-care consultant to coordinate the process of developing the guideline, and then finally the actual drafting of the national guideline. Now, the third stage, which is the critical one that we'll be focusing on today, is the implementation phase. And I'll be talking about that shortly. For the Ministry of Health in Uganda and the Self-Care Expert Group, we are keen on adopting a guideline that is feasible, acceptable, and applicable within the existing health system. As such, the implementation phase entailed integrating the drafted National Self-Care Guideline for Sexual and Reproductive Health within the public and private health sector and also the communities. assessing the implementation and adapting global frameworks such as the quality of care, the social behavior change communication and advocacy developed by the Self-Care Trailblazer Group, and also working together with the task team listed within the Self-Care Expert Group for Measurement and Learning, led by our partners, Makerere School of Public Health, to develop a measurement framework for self-care, and then collating all these learnings to inform the updating of the guideline. This process was iterative to enable us to develop and come up with a guideline that would be feasible and practical in our existing health system. The implementation phase had 3 different stages. The first was the preparation, the second was the implementation, and the last one being the monitoring and evaluation and learning. And I'll be looking at the different stages in detail. So the first, which is the preparation, entailed putting together a self-care curriculum for health providers and also trainers. And this was not on a skills training, but rather guiding the orientation of stakeholders on the guideline itself and how they can use it in the health system. The second is a district inception, which is the subnational level inception. For Uganda, the Ministry of Health with the Self-Care Expert Group selected 1 district, which has urban, rural community, fishing communities, basically a heterogeneous composition of the population to test the guideline. And this was also guided by time and resources. And then together with the district team, the Self-Care Expert Group led by the Ministry of Health selected 10 public health facilities and 8 private health facilities and a couple of village health team workers who would be oriented on the guideline and would work together through the implementation process. And then finally conducted the training for the health providers. So then we transitioned to the implementation, where the trained health providers now went back to the health facilities and cascaded the information on self-care guideline that they had learned to the other health providers within the health facility through continuous medical education sessions, and then followed it with the actual integration of self-care information sessions within their already existing health education sessions, for instance, the antenatal care clinics, where they were now talking about the self-care interventions and products that the expecting moms can actually utilize. Next was user training, product support, and continuity of care. So this is now the actual support, training the users on how to self-test, self-inject, giving them information, giving them the products, and maybe the drugs that they should be using. And then the district team is very supportive and very involved to conduct a routine support supervision in the time when COVID was still, when there was still restrictions, or do this virtually. The health facilities worked together with the district team to innovate around how they would manage data for self-care. And then, like I mentioned, working with the Self-Care Trailblazer Group, Advocacy Country Lead CHAD conducted a set of social behavior change communication awareness and advocacy sessions within the district for self-care. The last stage in this process was developing the learning, was the monitoring and evaluation. And this was led by the measurement and monitoring and evaluation task team nested within self-care, and it's led by our partner, Makerere School of Public Health in academia. They developed a set of learning questions and indicators, and the main learning question here is what is the best way of best approach of integrating self-care for sexual reproductive health within the existing health system, with sub-learning questions such as what would be the level of self-care acceptability in both public and private sector, among public and private sector health providers. How will adding self-care in the existing health system affect client experience, reduce health provider workload, waiting time at the health facility? How best can providers be involved in ensuring safety and strengthen the linkages of care among individuals practicing self-care? They also went ahead to come up with a set of indicators and draft together tools for collecting data, and also select where these data sources would be. For instance, the client records in the antenatal care clinics, the family planning register, the outpatient register, the cervical cancer register, among others. And then finally conducted the actual data collection, which was done through the joint support supervision and health facility assessment. And here the Self-Care Expert Group had conversations with health providers, the district teams, and also some of the self-carers. So what did we find when we went there to check on how the implementation is actually going? That was something that was interesting. Obviously, the self-care reduces has a different service pathway. A normal service pathway looks like the first one, where an individual, for instance, who wants to test for HIV comes to the health facility, goes through the triage process, and when from triage, they're directed to the consultation room where they speak with the health provider, directed to the laboratory where they will test for HIV, and then back to the consultation room, and then they're directed to maybe an art clinic if they're tested positive. For self-care, however, is the donor one. Same client with a self-test kit, tested positive, now comes to the health facility for a confirmatory, right? So through the triage to the laboratory for a confirmatory test, and then they're just directed straight to the... So it significantly shortens the service pathways. And we saw this with also the other set of services that are happening, and this is just an example. The other findings. We realized that for self-care to actually thrive in our health system, and for the case of Uganda, it's important that the health providers are skilled in supporting the practice of self-care. For instance, among the providers that we oriented initially on the guideline, only 16 out of 32 had the ability to support self-injection, self-testing. For HIV, for instance, support self-swabbing. So we think that this is a very critical element. 10 of the 18 facilities integrated self-care in health education routines, which makes it a sustainable way of sharing information on self-care. Almost all the facilities were engaging men in self-care and also involving adolescents. As they indicated, there was interest and uptake among those two categories. There were drivers that we looked at. The private sector drivers are not the same as the ones in public sector. The public sector proposition is that we're reducing client overload, reducing the queues, making service delivery really quick, and also involving individuals. For private sector, however, it might have to be a little different, as client overload usually translates into more money. So again, in the other outlets such as pharmacies and drug shops, self-care, because that is where they're selling the products, having quality products sold out, that is more money. So there is a need to have a value proposition for the different health service points. And then stock availability was such a huge determinant. In facilities where there was enough stock for self-care, the uptake was high. Where there was no stock, there would not be any uptake. So this is something that was critical. We also saw that provider support was coming off as a very critical element as a driver for self-care, and I will show you that in the next set of findings. So for us, among the health providers, there was positive perception of self-care and openness towards it. Those who were trained and in the facilities where we were test implementing. One health provider indicated that during antenatal care sessions, they do group testing for malaria. So everybody has a malaria rapid diagnostic kit, they prick together and test together, and then they are supported to read the results and directed to the next point. Whereas initially, if there were 30 women, then the 30 women have to queue up at the laboratory. So that is really serving them well. They also reported benefits such as reducing queues and service time. Awareness among and perception of self-care among individuals. We discovered of the 10 self-carers we talked to, we discovered that they appreciate health literacy, which is a critical component for self-care. So they are able to, they explain self-awareness as having information on health and using it to support themselves or manage their own health, which is a very key ingredient when it comes to scaling up and for self-care to thrive. We also, the interviewed self-carers also believe that self-care interventions save time and resources. They do not have to keep accessing the health facility. And this was also already seen in the scale-up of, like, for instance, self-injection. They are confident about practicing self-care because the products, information, instructions are got from a health provider. Now that again underscores one of the drivers that you mentioned there, that the health provider is still a critical part of self-care because they start the process of self-care as the individual goes out and manages their own health, but they continue to be a key point of information and support. And also that emphasizes the quality element and continuity of care. In terms of uptake of self-care, client service data shows a high record of self-carers in public health facilities compared to private health facilities. And we think that this is also attributed to data management and the regular health education happening in public health facilities compared to the private health facilities. So that also shows us that for us to be able to track and measure self-care accurately, we need to strengthen data management and also the integration of health education. The most available self-care products are those, such as indicated, the HIV self-testing was one of the most available, the folic, and the rest of these. In the facilities where we are doing the implementation, some had, like for instance, the self-injectable contraceptives and some did not, again still attributed to the issues of stock. The list available were the HIV self-sampling and the SGBV kit. These are still interventions in our package for Uganda, but they were list available, only found in 2 facilities. So that also again underscores the issue of stock availability. It was interesting to know that they were not looking at parallel data tools. They're using the same tools that they have to record client data. The only difference is that they would indicate an initial SC to indicate that this is a self-care client and this is just a regular client. So we found this is interesting. Even though Uganda is in the process of integrating more self-care indicators, they are already innovating around it. Again, like I mentioned earlier, the data management in private facilities is quite poor and needs to be strengthened. Health on continuity of care, health providers, especially those in public sector, feel that there's a need to have a robust follow-on mechanism. When clients come and pick HIV self-testing kits and go and test, they do not know whether they tested positive or they tested negative. How are they going to be supported further? So there's a lot of thinking and innovation that needs to go into that direction. Also, clients express fear of attaining wrong results without immediate support and counseling. So how, again, we think about integrating the counseling and support over self-care is very critical if we are looking at driving self-care. So what does this mean to all of us? We think that this iterative process is enabling us to see exactly how applying the self-care guidance that has been developed by the World Health Organization would look like in our health system. It's enabling us to identify the barriers and enablers, what the key things should be that we should be looking at both at country level, region level, and global level. If we are to see self-care fitting in as part of the health system and also leading us into achieving universal health coverage. For Uganda, this particular process is enabling us to come up with an applicable and feasible, reasonable guideline. And we've now taken the learnings and are in the process of integrating these and updating our guideline so that it is suitable to our existing healthcare system. And this can also be adopted by other countries that are interested in developing context-specific self-care guidances. I'd like to wrap it up by appreciating the team represented by, firstly, the self-care expert group, which I mentioned earlier is comprised by various partners, but also we have the strong leadership of the Ministry of Health. The self-care expert group is led by the Director of Clinical Services, supported by the Commissioner, Dr. Dina, and also our National Self-Care Consultant. And like I mentioned, our self-care expert group is hosted by PSI as the Secretariat. I'd also like to appreciate the Self-Care Trailblazer Group at the global level, giving us the guidances because of the frameworks that we're working with at country level developed by the SCTG. But also at country level, we have the Advocacy Country Lead, CHAT, who are supporting the advocacy I'll just take a second here for you to be able to see our websites and our handles where you can follow and get more information on what we are doing. And the QR code is basically my contact. Serving as a coordinator, I'm happy to share more information and link you to any other persons you might want to talk to regarding this process. Thank you so much.
Thank you. Yeah, thank you so much, for Precious, for that presentation. Our third presenter is Sanjita Gatiri, is the health advisor for Save the Children Country Office. She provides technical oversight to all health projects implemented by Save the Children in Nepal and has been an integral part of the Healthy Transitions for Nepal Youth project, which implemented the study on self-care for adolescents that she's going to present. Welcome, Sanjita.
Thank you and good afternoon, everyone. I'm presenting on behalf of our main author, Callie Simon, who's the ARH lead advisor for ARH at Save the Children based in Washington. My name is Sangeeta and I'm the health lead for the Nepal country office at Save the Children. So my presentation looks at the understanding of self-care interests, preferences, and opportunities for adolescent girls and young women in Nepal. In Nepal, adolescents and youth aged 15 to 24 make up nearly half of the total population, while over half of the country, while over half of the currently married women, 15 to 49, use contraception. The contraceptive prevalence rate is only 23% among currently married 15 to 19 adolescent girls, with just 15% of them using a modern method. Over a third of the Nepali adolescent girls and young women have begun childbearing by the age of 19. And in Karnali Pradesh specifically, where this project was implemented, it has the second youngest median age at marriage at 17.4 and first birth at 19.8, and the second highest adolescent childbearing rate in the country. Improving the ability of adolescent girls and young women to practice self-care by promoting and maintaining health with or without the support of a healthcare provider has potential to improve family planning RH outcomes for adolescent girls and young women in Nepal. Through its three dimensions of self-awareness, self-testing, and self-management, self-care can reduce the barriers the adolescent girls and young women face in accessing family planning, reproductive health information and services, and improve their ability to manage their health, including choosing to use contraception. Despite potential benefits of increasing self-care practices and options for adolescent girls and women in Nepal, very little has been done to accelerate self-care, and little is known about family planning, reproductive health, self-care interests, and preferences of adolescent young girls and women. This is an increasing recognition of the importance of self-care, especially after COVID, and some development has already started in terms of oral contraceptives, male condoms, self-testing for pregnancy, and self-injecting contraceptives like cyanopress to women in communities. In Nepal, cyanopress has already been tested for acceptance among women in communities within a limited geographic area. And the results show that there's high acceptance and preference for cyanopress as compared to the Depo-Provera or DMPA injections. However, there is a need for more research and discussions in the future to scale up in the community. So to address this gap, Research for Scalable Solutions, led by FHI 360 and Save the Children's Healthy Transition for Nepali Youth project, collaborated to learn more in Karnali Pradesh. From 2019 to 21, Save the Children and partners implemented the Healthy Transitions for Nepali Youth, a multi-level project that engaged adolescent girls, young women, their families, communities, and health systems to improve gender equality, family planning, reproductive health, maternal and newborn health among adolescent girls and young women and their communities. The project focused in Karnali province, which has the second youngest median age at marriage and first birth, and second highest adolescent childbearing rate in the country. So the aim of the research was to understand the interests and preferences and opportunities for family planning, reproductive health, self-care among adolescent girls and young women in 4 districts in Karnali Pradesh. Specifically, we explored interest in receiving family planning information on their own, comfort receiving family planning information from different sources, including through digital platforms, and comfort accessing contraceptive methods from different sources. In terms of the methodology, an external evaluation of the project was conducted. The baseline had 786 married and unmarried adolescent girls and women selected using a 2-stage random sampling from a list of project participants. The N line included 565 of the same adolescents, and the response rate was about 72%, were a set of questions related to interest and comfort using accessing family planning information and services without healthcare providers was included. The research team conducted a descriptive analysis on the self-care questions. So I'll go into the results now. So who were these Nepali adolescent girls and young women surveyed? There were a total of 565 adolescent girls and young women aged between 15 to 24 surveyed at the end line. Among them, 69% were aged 15 to 19, 38% were married, 65% were in school, and 33% had at least one child. So the majority of adolescent girls and young women were interested in accessing information on their own, meaning not through a health worker, on a range of contraceptive methods. 59% were interested in accessing information on their own regarding pills, 70% on information regarding condoms, and 63% on information on injectables, as well as 67% on pregnancy test. Among the unmarried and married adolescent girls and young women, 68% expressed interest in receiving information about how to effectively manage side effects or bleeding changes on their own, with no difference between married and unmarried. Since a lot of young women and young people were using phones, we also wanted to see if there were ways to get information and access of family planning information and services through phones, and assessed mobile phone ownership. More married adolescent girls and young women own mobile phones than unmarried adolescent girls and women, and among those who did not own mobile phones, managed to still get access to phones through family. Married and unmarried adolescent girls and young women were comfortable receiving family planning information from a variety of sources. More unmarried adolescent girls and young women were comfortable receiving family planning information via phone or digital platforms compared to those who are married. This slide shows the breakdown of sources, and as you can see, the comfort level of all adolescent girls and young women from all the various sources was quite high, such as the public, private, NGO facilities, pharmacies, female community health volunteers, and via phone or digital platform. So what are some of the implications for program? Expanding family planning RH self-care for adolescent girls and young women, including self-awareness and self-management, can mitigate barriers to family planning, reproductive health information, and services faced by adolescent girls and young women in Nepal. This study represents some of the first information about self-care interests and preferences from adolescent girls and young women in Nepal. The findings from this research offer important insights for the design and implementation of self-care interventions and strategies for adolescents and youth in Nepal, particularly related to the self-care awareness dimension of self-care. As most adolescent girls and young women are interested in accessing information related to contraception, pregnancy, and contraceptive-induced menstrual changes on their own, there's a clear opportunity for expansion of self-care to improve family planning and RH among adolescent girls and young women in Nepal. Further, the adolescent girls and young women indicate very high levels of comfort accessing information and contraceptives from female community health volunteers and public health facilities, suggesting the importance of engaging these actors in the provision of information and support for family planning, reproductive health self-care. Differences in mobile ownership, interest, and comfort level in family planning, RH, and self-care between unmarried and married adolescent girls and young women is notable and suggests that the importance of tailored self-care strategies for unmarried and married adolescent girls and young women. For example, unmarried adolescents, while they have a lower mobile phone ownership than married adolescents, they were more comfortable receiving family planning information on the phone and digital platforms. This suggests the promise of phone and digital self-care interventions in Karnali, while pointing to the need of non-digital self-care strategies to address the inequity in phone access by marital status. And that's it. Thank you very much for your attention.
Thank you very much, Sanjita. We'll go now to the last presentation. Unfortunately, the last presenter could not be with us today. Dr. Diodon Bidashimwa is an associate scientist at Family Health International, where he serves as the principal investigator of the self-care project and a Research for Scalable Solutions grant. And he has recorded his presentation, which we are going to play and then have the questions.
International 360 in Durham, North Carolina, in the United States. And today, I have the pleasure to present the results of an exploratory mixed method study of family planning self-care that FHI 360 conducted in partnership with Makerere University and EVEDAF in Nepal, Niger, and Uganda. The study was conducted as part of the Research for Scalable Solutions, which is a 5-year USAID-funded project that Family Health International is conducting in partnership with the organizations presented at the bottom of the slide.
Can we have the sound?
For this study, we adopted the World Health Organization's definition of self-care, which is the ability of individuals, families, and communities.
Sorry.
Are you going to run the video this now, or?
Yes, we want to hear.
Okay.
Gentlemen,
Oh, when you want to start the video, you click the space bar.
dear colleagues, good afternoon.
It's okay.
My name is Diodone Bidashimwa. I am Associate Scientist at Family Health International 360 in Durham, North Carolina, in the United States. And today, I have the pleasure to present the results of an exploratory mixed method study of family planning self-care that FHI 360 conducted in partnership with Makerere University and EVEDAF in Nepal, Niger, and Uganda. The study was conducted as part of the Research for Scalable Solutions, which is a 5-year USAID-funded project that Family Health International is conducting in partnership with the organizations presented at the bottom of the slide. For this study, we adopted the World Health Organization's definition of self-care, which is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a health provider. And the WHO has a framework, a self-care framework, which is made of 3 components, including self-awareness, self-testing, and self-management. And we used this framework and adapted that to the family planning context and came up with 3 components, which are awareness, or ensuring understanding of fertility and contraceptive options, access, providing access to contraceptive options, and usage, support management of the chosen contraceptive methods. Our study objectives were to explore how women understand self-care in the context of family planning and describe family planning behaviors and preferences as they align with awareness, access, and usage. Before we move on with the presentation, I'd like to highlight that beyond those objectives, the study also aimed to understand family planning self-care among men and providers, measure behaviors and preferences among women qualitatively, and measure behaviors and preferences among men both quantitatively and qualitatively. But this presentation will focus only on women. So we conducted a cross-sectional mixed method study in Nepal, Niger, and Uganda to answer our research objectives. Women were sampled using a cluster sampling design, and they were eligible if age 15 to 49 years old, married or having a recent relationship, or using family planning methods, or having unmet need for family planning. And we recruited women in 25 enumeration areas in Nepal and Niger, and 28 enumeration areas in Uganda. And the final sample for both the survey and the in-depth interviews are shown in this table. So for the results, I will first present the qualitative results on understanding of self-care among women, and then the second part of the results section will focus on the quantitative, the survey findings on behaviors and preferences. Generally, as suggested in this quote from Nepal, women across all three countries related the concept of self-care to personal and or family health and hygiene behaviors that would keep them healthy, as well as seeking medical care when needed. When directed to apply this to family planning, participants identify the use of method, whether traditional or modern, to space or limit family size. While women in Uganda put somewhat more emphasis on modern spacing methods, women in Niger and Nepal were likely to mention traditional methods. In terms of awareness, family planning self-care meant having the information needed to choose and use a method well. If calendar method, for example, that meant understanding the menstrual cycle. Although the findings highlight the importance of understanding the menstrual cycle as a component of family planning self-care, there was a mixed understanding of most and least fertile days in all three countries, as suggested in these quotes from Uganda. Family planning self-care also meant knowing about the range of modern methods, how they are used, and what side effects to expect. Participants across the three countries prioritized accessing information and methods through public health clinics and their providers. However, in Nepal, the role of private clinics and pharmacies and drug shops, as well as community-based health volunteers, was frequently mentioned. In both Niger and Nepal, men played a pivotal role in accessing methods. In Niger especially, men's tacit approval was expected from healthcare providers, although across the three countries, some women engaged in family planning use without such approval, as described in this quote by a woman in Niger who obtained injection when her husband was traveling. Finally, descriptions of self-care approaches to methods used also varied. For some couples, it meant shared decision to practice restraint through use of condom, withdrawal, or calendar methods. More women in Uganda than other countries described selecting and using a modern method that did not require male partner involvement. Self-care could be challenging if a method led to intolerable side effects, especially menstrual cycle disturbances. And the inability to adequately manage side effects might lead women or couple to stop contraception use and use a more traditional method with fewer side effects. As this final quote from Nepal suggests, the decision to stop or switch to a more suitable method was also considered to be a sign of self-care. So the rest of the presentation will now focus on the quantitative findings. The mean age of the sample was around 30 years old in the three countries. Most women in Niger and Nepal, and about half the sample in Uganda, were married and from urban areas. About half of the participants had at least a secondary level of education, except in Niger, where education was low. Across the three countries, the number of children ranged between 2 and 4, with the lowest number in Nepal and the highest in Niger. Niger also had the lowest proportion of users of modern contraceptive methods at 33%, while the contraceptive proportion in Nepal and Uganda was 56 and 57% respectively. These numbers are higher than available national estimates on modern contraceptive prevalence rates in the three countries, which is normal given our inclusion criteria. In this slide, we present results on awareness of contraceptive options among women. And our results show that when it comes to knowledge of family planning methods, the quasi-totality of women knew at least one method of family planning. This ranged from 96% to 100% in the three countries. Generally, women were also knowledgeable of places from where they could access family planning methods. As shown in this figure, women were most aware of family planning service points within the healthcare setting. So those include health posts, hospitals, and health centers. For family planning delivery points available outside health facilities, community health workers, drug shops, or pharmacies were cited as the most common sources, followed by outreach events and markets and shops. Overall, we note some variation between countries, especially in Niger and Uganda. Women were more likely to report healthcare facilities, hospitals, drug shops, and pharmacy. Whereas in Nepal, it was a little bit, there was more variation in the type of places known by women, but essentially we see that most women knew health posts, hospitals, drug shops, and community health workers. Next, we measured the sources from which women accessed their family planning methods, doing method initiation as a measure of access, referring back to our framework, and method resupply as a measure of usage. To limit bias in measuring the source used at method initiation and resupply, we asked women to refer to the most recent episode of continuous use. This allowed to provide an objective reference point for those who have stopped and restarted a method at different times in their contraceptive journey. So the results on the left table are those at most recent initiation, and the result shows that women across the three countries obtained a method from health facilities, especially facility-based providers, including at health centers, health posts, hospitals, in Uganda especially. Drug shops or pharmacies were used as the main outlets for initiating methods outside the healthcare setting, especially in Nepal and Uganda. The use of other sources, such as community health workers and mobile clinics for family planning initiation, was not highly prevalent in the three countries. Among current users of family planning who have refilled the method at least once, so now we're shifting on the result in the right table. So among those women, the sources they used at the most recent resupply overlapped with the sources used at recent initiation, with facility-based providers leading as the main source, and other non-traditional sources were not very prevalent. However, in Uganda and Nepal, we observed a decrease in use of health facilities as a source of family planning methods between initiation and resupply. At the same time, as shown in the numbers circled in green, we see that there was an increase in use of non-traditional sources, especially drug shops, pharmacies, and community health workers, between the initiation and the resupply in the two countries. In Niger, reliance on health facilities is particularly high for both initiation and resupply. This slide presents results on women's behaviors around the management of contraceptive side effects, which is a dimension of family planning usage. The proportion of women who have ever experienced side effects among users of hormonal methods was 35% in Niger, 57% in Nepal, and 73% in Uganda. And among these women, most of them sought assistance from providers to manage side effects. The most reported sources of assistance of side effects outside facility-based providers was friends or relatives in Niger, community health workers in Nepal, drug shops, and friends or relatives in Uganda. And among those women who experience side effects, we see that there are some women who attempted self-managing side effects. And the proportion was 47% in Uganda, 33% in Nepal, and 25% in Niger. Assistance for a provider or self was mainly sought to manage contraceptive-induced menstrual changes, including heavier, longer, or irregular bleeding. Lastly, we asked women about their preferred channel for accessing family planning services. Most women prefer accessing their method of getting assistance for side effects, mainly from providers in Niger and Uganda and community health workers in Nepal. And these preferences are the same for pills, emergency contraception, self-injection, and side effects management. Most women perceive that it was very important to involve a healthcare provider when initiating or refilling pills, emergency contraception, or self-care or self-injection. This perception was higher for pills in Niger and Nepal, and for self-injection in Uganda, as we can see in this figure. And we also see that across the three countries, the perception was lowest for emergency contraception. Also, the positive perception toward providers' involvement was higher for method initiation than for refill in the three countries. This finding aligns with the pattern seen in women's declared channel for accessing methods, whereby they have a higher reliance on facility-based providers for method initiation than for refill. In conclusion, women's qualitative understanding of self-care and family planning was broad, but upon probing further, women in the three countries linked self-care for family planning to contraceptive knowledge, means of accessing and using methods of choice, as well as means of managing side effects. As such, self-care perceptions in the three countries align with our conceptualization of self-care as a concept applicable to family planning awareness, access, and usage. Most women in the three countries rely on providers in the healthcare setting to access family planning, information, commodities, and to manage side effects. However, some women refill their family planning methods from non-traditional sources such as pharmacies and drug shops, mostly in Uganda and Nepal. There is some indication that women attempt to self-manage contraceptive side effects at varied degrees across countries. Finally, results note the importance of the important role of linkages to the health system among women. Our partial results will be more complete when we triangulate them with results from men and providers. So stay tuned to learn more about this study. To finish, I'd like to acknowledge the broader team of partners in different organizations who contributed to this study in Niger, Nepal, Uganda, and the United States. Thank you very much for your attention.
Yeah, thank you all for your attention. That brings us to the end of the presentations. We have about 10 minutes that we can use for Q&A. We have two microphones, one behind the camera and another one in front here. So those who have questions, please just come to the microphone. And meanwhile, I ask maybe the panelists to come and sit in front here where we have microphones so that we can use them to respond. We'll take the first 2-3 questions and then we can be able to close. So any questions? Please, if you have a question, just go to the microphone in the middle of the room. Yeah. I don't see any hands up. Looks like the presentations were extremely clear, or we come from places that are many hours behind. Yeah, so maybe I'll ask some question just to get reflections from the presenters. So we've had a lot of studies about that are in the context of self-care, but a lot of the results are generally about family planning. They are not unique to self-care, and I think we saw even with the last presentation that maybe women's experiences. So I would just like the panelists to reflect, like compared to accessing services from a health provider in the area you studied, what would you say was the most striking difference in terms of women's experience that was strikingly different, that came out that this was really unique, and you could attribute to the fact that this was self-care, whether you are talking about in Uganda self-testing or in Nepal or in Mozambique? What would you say was really the unique difference that probably you could not have seen these kind of findings if these were services being provided by providers? So Sanjita, we can start with you and then come this way.
In our case, I guess the only uniqueness is the fact that we were trying to assess the use of mobile phones among adolescent girls and women for accessing information. And surprisingly, in our case, we had married women having access to mobile phones. And I think that is because we have more migrant populations in the rural areas, and the husbands tend to give mobiles to their wives just to keep in touch. And that's how they have more access. While adolescent girls who are unmarried are more comfortable using mobile phones, but don't have access to mobile phones. So I think that difference was quite unique in our findings here.
Thank you. Yes.
As you know, our study was assessing the implementation of the WHO guidelines for the 3 different health areas for family planning and safe abortion and STIs, HIV and cervical cancer. And our most kind of striking finding was that self-care for family planning was a lot more advanced, but self-care for the other 2 health areas were definitely a lot further behind. So I would say that's kind of our main takeaway from the study, from the policy mapping.
Okay, thank you. Yes, Precious.
For the test implementation of the guideline in Uganda, I think we were looking at all the self-care intervention packages, so not just family planning alone. So we realized, I think what was most standing out for us was the drivers for self-care and the difference of how it is in public sector and in provision of the self-care products vis-a-vis in private sector. I think overall, realizing the different enablers and barriers in the health system and how that is impacting the practice of self-care was quite interesting. For instance, how the provider role comes in critically to support the access and utilization of self-care, and also the other issues such as stock availability for across all the self-care interventions. So those are some of the things that were really coming out very uniquely.
Okay, thank you so much. I think my kind of maybe looking at the presentations, I would like to say that probably self-care is some area that is really growing, is an area that also brings very different contexts, whether you are talking about the phones and who owns a phone, who knows how to use, whether you are thinking about which area is in alignment, or the issues that were found in Uganda. So I think it is an area that we really need to treat with, as we implement, to document very well, because we will be learning a lot of lessons as this is rolled out. But thank you so much for keeping with the session. We know it's late in the day and many of us are ahead of the hours that we usually are at. So thank you so much, and let's really thank all the presenters for the great job.